Hey guys, it's Amog, and today we're going to be talking about ischemic heart disease from a clinical science perspective. Our learning objectives today are to identify the risk factors for ischemic heart disease, differentiate between the signs and symptoms of myocardial ischemia versus infarction, apply the use of EKGs and cardiac biomarkers in the diagnosis of myocardial disease, talk about treatment options for patients with myocardial ischemia, and explain the physiologic principles behind therapy for myocardial infarction. Okay? So, our cases to think about as we go along through the rest of this lecture. Got a 51-year-old male presents with chest tightness of 1 month duration. This occurs when he's walking upstairs or lifting things, but it's relieved with rest. The same 51-year-old male presents to you 1 month later with chest discomfort and shortness of breath of 1 week duration. The pain is associated with exercise, but is no longer relieved with rest. And finally, that same 51-year-old male presents 1 week later with a crushing chest pain radiating to the left shoulder of 3 hours duration. He is sweating profusely and is also complaining of shortness of breath and lightheadedness. Okay? So, just to briefly review the pathology and pathophysiology of this ischemic disease, to kind of recap Steve's lecture, we have two major types of pathology. The first is myocardial ischemia, which is basically just diminished blood flow to the heart muscle, resulting in a temporary ischemia. And this process is entirely reversible. So if we get in there in time and we restore blood flow, we can keep the muscle from dying and we're all good. Myocardial infarction is persistent ischemia that leads to the necrosis of that heart muscle, and this process is irreversible. So I'll talk about these two processes as distinct entities, but really it's a continuum that you lie in between. The best thing you could have in this case would be myocardial ischemia, and progression to the worst possible thing you could have is myocardial infarction. So there's a continuum with ischemia being reversible, infarction being totally irreversible. So what are some of the risk factors that we know of for this type of disease? So the first is age, gender, and family history. These are all non-modifiable. They're part of who a patient is, and they can't really change it. After that, we have things like hypertension, hyperlipidemia, diabetes. Now, these things can be genetic or they can be associated with family history, but for the most part, these are conditions that we can treat. So we can give medication for blood pressure, we can give medication for cholesterol, we can give medication for blood sugar, and this can help reduce the risk for eventual development of ischemic heart disease. Finally, among the risk factors, we have things that are called lifestyle modifications. So smoking, huge risk factor for heart disease. Obesity, another huge risk factor for heart disease. Going along with obesity, you have sedentary lifestyles, so people who aren't very active. Again, very, very high risk of heart disease, and people who drink considerably are also at an increased risk of heart disease. So we can kind of think about the risk factors as things that we want to ask about in our history when we're talking to the patient. We want to ask them about the family history of any heart disease in the past, sudden death or heart attack or anything like that. We also want to ask them about their past medical history, if they have high blood pressure issues, they have cholesterol, they have diabetes, and then related to their social history, are they smokers, are they drinkers, and do they have a relatively active lifestyle? So these are all things that are important aspects of our patient's history. So clinical definition. So how do we actually differentiate between the different parts of that continuum that I was talking about? So the first condition that we're going to talk about is called stable angina, and that's basically defined as chest pain or discomfort associated with exertion and lasting less than 20 minutes. So the key thing is that if it's stable angina, it's associated with exertion, so exercise, emotional stress, anything that's going to kind of put the heart into exertive mode. That's going to trigger this type of chest pain. Again, it's reversible, so it doesn't last very long, usually less than 20 minutes, and it's entirely reversible. The next step on the continuum is unstable angina. Now, unstable angina is a little bit worse than stable angina because it occurs at rest. It's not associated with exercise or emotional stress or anything like that. It can occur at rest if you're just sitting in the chair. So it's slightly worse, but again, it's reversible. It lasts less than 20 minutes, and for the most part, damage done by unstable angina is usually always something that we can kind of use medications for and restore that blood flow, and we don't really have any lasting effects. The final part of that continuum is myocardial infarction. This is what we call a heart attack. Severe, crushing chest pain not associated with exertion or rest, so it can really happen at any time and lasts longer than 20 minutes. Now, just by knowing that it lasts longer than 20 minutes, you're probably guessing that, yes, this is not a reversible process. It takes a long time. It lasts a long time. And this is because our heart muscle is actually undergoing necrosis. It's dying. We can't repair it. The only thing we can do is kind of stabilize the patient and try and preserve as much of that heart muscle that's remaining as we can. Okay, so these are the three clinical definitions that we're going to work with. We're going to talk about signs and symptoms and then how we actually treat them in the rest of the lecture. So, signs and symptoms, starting off with stable angina. So things that we want to ask about in the history, specifically the history of present illness. So chest discomfort. Usually patients describe it not as much of a sharp stabbing pain, but they actually describe it as a squeezing or a tightness or a pressure. They usually have a difficult time locating it. They kind of just say, oh, it's in the chest, but can't really point to a specific location. And again, it's stable angina, so it's triggered by physical activity, cold, emotional stress. The vast majority of patients with stable angina will have pain that lasts usually 2 to 5 minutes. Okay, so again, less than 20 minutes is the kind of cutoff, but most patients have episodes of this anginal pain that lasts usually 2 to 5 minutes. And other associated symptoms that you want to ask about in the review systems are things like shortness of breath, nausea, and vomiting. This just has to do with the degree to which they were feeling the pain. Nausea, vomiting, shortness of breath are all kind of generalized symptoms that can be nonspecific, but in this case, they tell us really how severe that pain really was. Okay. In terms of a physical exam, there's not too much to do in terms of a cardiac exam, but really we're going to focus on vitals. So after the patient experiences this type of event and the heart is put under some ischemic stress and they can't get enough oxygen, it's going to try and compensate by pumping a little bit faster just to try and get blood to the tissues that aren't getting enough oxygen. And this is going to drive up our heart rate. It's going to drive up our blood pressure. So you're going to see tachycardia on your vitals. You're also going to see some hypertension. For unstable angina, it's going to present relatively similarly, chest discomfort, diffusely located, but the key difference is that it's not associated with specific triggers. It can occur at rest, just when someone's sitting down and kind of relaxing, they can start having this type of pain. But again, it usually only lasts about 2 to 5 minutes because it's a reversible process. On physical exam, it's going to be very similar to stable angina. They're going to be tachycardic and they're going to be hypertensive. And this is mainly because, again, of the ischemic insult to the heart. It's going to try and compensate by pumping a little bit faster and trying to perfuse as much of the tissue that it can in order to basically compensate and save itself. Myocardial infarction is going to be very different. You're going to have chest pain. Patients are going to describe this as real pain. It's going to hurt quite a bit. It's going to be crushing pain, as if someone's sitting on their chest. Okay. Usually, patients describe the pain radiating to the arms and shoulders, usually left more than right, and that's mainly because the heart is on the left side of the chest. It can occur at rest, not really associated with exertion again, and it's going to last longer than 20 minutes. This is important, again, because we know that this process is irreversible. Usually on our review systems, they're going to report shortness of breath, belching, nausea, vomiting, dizziness, and fatigue. And again, these are all generalized symptoms that are telling us that the body is experiencing a significant injury that kind of needs to be dealt with accordingly. On physical exam, again, we're going to be tachycardic and hypertensive, but in the case of MI, you're also going to see patients who are sweating. Their skin, they're going to be profusely sweating, and their skin is going to be cold and clammy. And this is mainly because as we try and respond to this ischemic injury to the heart and essentially infarction, this necrotic tissue, we're going to try and redirect our blood supply as much as we can and try and preserve as much as we can of the heart. So we're going to get less blood flow to the extremities into the skin, so you're going to get cold, clammy skin, and they're going to be sweating just kind of as a response to the significant injury that's occurring in the heart. So how do we actually diagnose stable angina versus unstable angina versus MI? Really, the majority of it's based on our history and physical. So identifying risk factors, identifying symptoms in the HPI, and then doing a physical, quick physical, just doing vitals and a general appearance to see how they're actually responding. That's going to be the single most important factor in diagnosing these conditions. That said, we can do a few diagnostic tests. The first is an EKG. Now, I'm not going to go into a lot of details about the EKG, but really when we're thinking about ischemic heart disease, we're looking for two findings, one or the other, when we do an EKG. The first is ST depression. ST depression, and I'll go through what that looks like in the next slide, but ST depression is indicative of subendocardial ischemia, which is the case in stable and unstable angina. So it's just a reflection of a temporary reversible injury that's happening beneath the endocardial layers of the muscle. So it's not a complete ischemia. It's not a complete destruction of the muscle wall, and that makes sense. We know that stable and unstable angina aren't total necrosis of the wall, but we are talking about ischemic injury to some portion of that wall. And when we see that on EKG, it's going to look like ST depression. Conversely, ST elevation is what we get when we get the entire heart wall that is ischemic and essentially gets infarcted. And this is what happens when we have an MI. So the key differentiation points are, if we do an EKG and we see ST depression, okay, we're thinking this is a relatively reversible event, stable or unstable angina, and then we can treat accordingly. If we see ST elevation, okay, we know it's infarction, this is significantly more serious, and we need to take the next steps accordingly. The next diagnostic testing that we can do is looking for cardiac biomarkers in the blood. And essentially, what this allows us to do is look for components or biochemical markers that are only found in cardiac muscle. And when cardiac muscle breaks down and dies, those cells break down and release their contents into the blood. So if we find that some of these contents are in the blood, that we know that cardiac muscle has basically been destroyed. So the two things that we look at are troponins and CK-MB, okay, creatine kinase MB fraction. And these two enzymes are specific to the heart muscle. And so if we see them in the serum above a certain level, that we know that we've essentially had infarction. And this is a pretty widely used indication that we've confirmed myocardial infarction. Okay, so just briefly, we'll talk about EKGs and then we'll move on to workup and treatment. So EKGs just represent the electrical conduction of the heart. The P wave represents atrial contraction, the QRS complex represents ventricular contraction, and the T wave basically represents restoration back to normal baseline. Okay, so when we're talking about the ST segment or ST elevation or depression, it's this area right here. And the process that's going on here is that we're starting the repolarization phase of the essentially the conduction cycle. And so what the ST segment tells us is that if we're able to repolarize that tissue or not. If we're able to repolarize it, but the ST segment is low, that just means that only a part of that tissue has been ischemically insulted. If we're entering the repolarization phase and it's up high, that means that essentially the entire wall has been infarcted, and it takes basically the current is going to, the segment is going to be up here rather than down here normally. And this is a pretty good illustration of that. So the ST segment basically represents repolarization of the ventricles, like I said, and this is what a normal waveform would look like. It doesn't look as pretty as this one, but usually that's what it looks like on a normal EKG. And so if we have subendocardial ischemia, so stable or unstable angina, we can get ST depression, and this is what it looks like. It can either slope downwards or it can just be straight down here, and this represents that subendocardial level of lack of oxygen, and only part of the heart muscle wall has been exposed to ischemia. Whereas if the entire wall, transmural ischemia, in the case of a myocardial infarction, that SC segment's actually up here. Okay, and so you can see how it's significantly elevated from down here, and that is just an easy way for us to tell the difference between a transmural ischemia and a less severe subendocardial ischemia. Our biomarkers, again, they're released as the necrotic cells are broken down, and mainly we're talking about troponins and CKMB. We can also look at myoglobin. Myoglobin's less specific simply because we know that myoglobin's not just found in cardiac muscle, but it's found in all other muscles. So having it in the serum doesn't necessarily tell us that there's a cardiac injury. But this graph just shows you the time course of when how long it takes for some of these biomarkers to peak in the serum, so how long it takes for them to eventually drift away into the blood to a level that we can detect. And so here myoglobin would be first, but again, it's the least specific. After that, the CKMB is going to peak, and after that, the troponins are going to peak. So usually what we'll do in the hospital when we're suspecting someone's having an MI is we'll draw blood and look for these biomarkers and trend them over time. So we'll see if they're gradually increasing and eventually peak for both CKMB and for troponins. But remember, while these diagnostic tests are great, and we can do EKGs and we can look for troponins and CKMBs all we want, our H&P is the most important part of, one, diagnosing the patient, but two, deciding whether it's an emergency or not. You'll be able to tell if a patient is coming in with severe chest pain, they're sweating, they're nauseous, they're vomiting. In that case, we know this is an emergency and we need to do something fast, as opposed to someone who just comes in and says, you know what, I have chest pain every time I walk up the stairs. It goes away on its own. In that case, we don't really think it's an emergency because we know that that patient is undergoing reversible ischemia. Okay? Depending on the severity, angina can actually be managed on an outpatient basis. So if they have stable or unstable angina, they can actually be managed as an outpatient. But again, MI is the thing you don't want to miss because, one, it kills one of the largest numbers of people in the entire world. I believe it's one of the top causes of mortality all over the world, not just in the U.S., and it's an emergency that needs to be treated and addressed right away. So how do we actually decide what to do with these patients? How do we treat them, and how do we categorize them as someone who needs outpatient therapy or immediate intervention right away? So for suspecting stable or unstable angina just based on their history, what we can do is give a medication called nitroglycerin. Nitroglycerin, what it does is it dilates our veins and essentially allows more oxygen to be delivered to that ischemic area because we're dilating our vessels and allowing more blood to flow into the place that wasn't originally getting too much flow. So if we have relief with nitroglycerin, we can definitively diagnose stable angina. So if we can reverse the pain just by giving nitro, then we can say this patient has stable angina and we can manage them as an outpatient. However, if we give nitro and there's no relief, we can diagnose this patient with unstable angina. So essentially what needs to happen is that we give, so let's say someone comes in right away and we give them nitroglycerin, complaining of chest pain, and they don't have relief, then we're either thinking about unstable angina or possibly something worse. But if that pain goes away on its own, then we know it's unstable angina. Okay, so pretty easy to differentiate between stable and unstable angina. Okay, after we do that and we establish whether they're going through stable or unstable angina, then we can look at doing a cardiac stress test and doing an echo to assess overall cardiac function. After that, we can also do a diagnostic cath, where we basically take a catheter in and take pictures of the blood vessels that are supplying the heart to see how bad the stenosis or narrowing of those vessels is that might be causing that patient's pain. But again, these are things that can be scheduled on an outpatient basis. They're not emergent, but they will help us kind of predict, okay, if this patient has a really, really, really small coronary artery, then we know that they're probably going to have these symptoms again soon. So then we can decide what to do accordingly. In the case of myocardial infarction, we want to do some significantly different things. Okay, so it's not just as simple as giving nitro and seeing how they respond. If we know that they're having an MI based on their history and their clinical presentation, their EKG, they have troponins that are elevated, CKs and MBs that are elevated, the first thing we want to do is increase oxygen delivery to the heart muscle in order to reperfuse as much as we can of the remaining heart. So we do this by, one, hooking them up to oxygen, and two, taking them to the cath lab where we can actually go in with a catheter, find the artery that's being blocked, and we can actually either put a balloon in there and widen that artery, or we can put a stent in there to basically sit in the middle of the vessel and open it up and increase the diameter. Okay, both of these things will allow increased oxygen delivery because we're increasing blood flow to that area to reperfuse as much of the heart muscle as we can. Okay, after we do that, that's kind of the most important thing that needs to be done right away. After we do that, what we want to do, our goal is to reduce strain on the heart because the heart just went through this significant injury. We want to make sure that it doesn't have to work as hard as it absolutely needs to. So from physiologic terms, we know that the two ways to do this are to reduce the preload. We talk about preload versus afterload. Preload is essentially the amount of blood that's filling the heart, and afterload is the amount of pressure that the heart has to pump against. So if we reduce preload, then the heart doesn't have to pump as hard to get it out. And if we reduce afterload, reduce the pressure that it's pumping against, it doesn't have to work as hard to empty itself. So it makes a lot of sense from a physiologic perspective. Now, ways that we reduce preload, again, we can give them nitroglycerin to dilate their vessels and allow basically less blood to return into the heart. We can also give them a beta blocker to slow down their heart. When we're talking about reducing afterload, we want to give them a drug called an ACE inhibitor, which is essentially going to reduce the systemic blood pressure overall and decrease the pressure that the heart has to pump against. Finally, the last thing we want to do is prevent future clots from forming because in this case, the most common thing that's going to cause an occlusion of a coronary artery, an artery that's supplying the heart muscle, is any type of clot or thrombus that's going to go in and lodge itself in the vessel and prevent blood from going through. So we want to anticoagulate them. So we want to give them aspirin and clopidogrel, both of which are going to prevent us from forming clots and kind of thin out our blood as much as possible to prevent any future occlusions from developing. Okay. Now it's not important for you guys at this level to know every single drug here, the names of the drugs, mechanisms of drugs. All of that's not important, but it is important for you guys to understand this part. So this is all physiology, right? We have an infarction. We know what an infarction is, right? Persistent ischemia leads to necrosis. So it makes sense that we want to increase oxygen delivery. It makes sense that we want to reduce strain on the heart, and it makes sense that we want to prevent future clots from forming because that's what caused that decreased oxygen delivery in the first place. So now let's go back to our cases and think about how we would categorize each of the presentations and then what we would have done at that point in time. So at first we have this 51-year-old guy comes in with chest tightness of 1 month duration. Occurs when walking up the stairs or lifting things but is relieved with rest. So this sounds like stable angina. So in this patient, we see that he's having these episodes of discomfort, but it's only associated with exertion. So if he comes into the hospital and he's feeling the pain right now, we could give him nitroglycerin and see how he responds. In the case of stable angina, he's going to respond pretty well. He's going to be relieved. And in that case, we would schedule a stress test, an echo, and if necessary, we do a diagnostic cath based on the results of those tests to see how we'd like to manage him further. But again, this is not going to be an emergent condition. We can kind of calm him down and explain to him what's going on, and then figure out what the next steps are in terms of managing him on an outpatient basis. Okay, but he comes back to us 1 month later with chest discomfort and shortness of breath of 1 week's duration. So it's been a month, and now he's been feeling chest pain, shortness of breath for a week. It was associated with exercise like it was previously, but it's not really relieved by rest anymore. So in this case, if he comes into the hospital feeling this way, we can give him nitroglycerin, see how he responds. If he doesn't respond to nitro and we know it's not relieved by rest, we know that we can make a diagnosis of unstable angina. So Again, if we haven't done those tests already to kind of diagnose um, why he's having this unstable angina, so understand um, if he's got a specifically narrow artery in one of his coronaries, we would want to do a diagnostic cath, see where that stenosis is, and then assess his risk for potential MI later on. But then unfortunately, it comes back a week later with crushing chest pain. Unfortunately, you probably weren't able to get that test. Crushing chest pain, radiating to the left shoulder of 3 hours duration. What does this sound like to you? Probably sounds like an MI. He's sweating profusely and is complaining of shortness of breath and lightheadedness. So he's got a constellation of symptoms, systemic symptoms. In this case, he probably has an MI, right? So what are our goals for treatment? How are we going to decide what to do with him? One, we want to increase oxygen delivery to his heart muscle, so to revascularize him, so take him to the cath lab and try and open his vessels up if any way possible. We want to hook him up to oxygen and increase O2 delivery to the myocardium. And then we want to basically reduce his preload, reduce his afterload, and prevent any future clots from forming. Okay, so that's essentially our treatment approach. Again, when we're talking about diagnosis, here we gave you a clinical scenario. Just based on his history, we have a really high index of suspicion that he has an MI. In most hospitals' cases, they will still do an EKG and do troponins and CKMB, but just based on the history, we have a pretty good idea of what this patient has, so we can start formulating our plan based on that. So again, back to our learning objectives, we wanted to talk about risk factors, which we did. We want to differentiate between the signs and symptoms of myocardial ischemia and infarction, so the differences between stable angina, unstable angina, and myocardial infarction. We want to talk about the uses of EKGs and biomarkers in the diagnosis of myocardial disease, and we emphasize that the H&P is really the most important part of diagnosing myocardial disease, but we can use EKGs and biomarkers to our benefit to kind of give us a little bit better idea of what's going on. We also talked about the treatment options for patients with myocardial ischemia, mainly nitroglycerin, and then we also talked about the physiologic principles behind therapy for MI, including reducing preload, reducing afterload, increasing oxygen delivery to the heart, and also preventing future clots from forming to prevent future ischemic events. Okay, so that's all I've got for you guys today. Hopefully this was helpful, and I'm looking forward to seeing you guys this week.